Welcome to SLP Nerdcast. I'm Kate.
And I'm Amy, and we appreciate you tuning in. In our podcast, we review and provide commentary on resources, literature, and we discuss issues related to the field of speech-language pathology.
You can use this podcast for ASHA CEUs. Visit our website for other courses, including live courses, webinars, blog posts, and SLP Masterclasses available for graduate level credit. SLP Nerdcast is committed to improving continuing education in our field through affordable pricing and open access libraries. You can support our work by leaving a review, referring a friend, making a one-time contribution on our website, or subscribing. You can subscribe for as low as $7 a month and get access to monthly Q&A sessions, exclusive content, discounts, and a resource library of downloads, freebies, and printables. Want unlimited access to ASHA CEU courses? There's an affordable subscription for that too. For more information, visit us on our website or contact us anytime on Facebook, Instagram, or at info@slpnerdcast.com. We love hearing from our listeners, and we can't wait to connect with you.
And just a quick disclaimer, the contents of this episode are not meant to replace clinical advice. SLP Nerdcast, its hosts, and guests do not represent or endorse specific products or procedures mentioned during our episodes unless otherwise stated. We are not PhDs, but we do research our material. We do our best to provide a thorough review and a fair representation of each topic that we tackle. That being said, it's always likely that there's an article that we've missed or another perspective that we haven't shared. If you have something to add to the conversation, please email us. We love hearing from our listeners.
Today's episode, we get to welcome back someone who has been on our podcast before, who we have so much fun with. As a matter of fact, before we even hit the record button today, we've been chatting and laughing for about a half an hour. So we're really excited for today's guest. We are really excited. We're really excited for today's guest. Welcome back, Dr. Lindsay Griffin.
Thank you. Thank you for having me. I too am excited to be here.
It's always nice to see you. And today you are here with us to discuss complex airway management. Before we get started, can you please tell us a little bit about yourself?
Sure. So I am Lindsay Griffin, and I work at Emerson College, where I am an assistant professor. My main topic area is dysphagia or swallowing difficulties in adults specifically. But given my clinical background of working in acute care and in rehab, I also have some clinical experience in complex airway management.
I'm very excited to learn about what that is, because as our listeners know, this is very far out our scope of competence and knowledge base. And you're going to teach us all the things, as you always do, with a couple laughs along the way, I would be willing to bet. So this is very exciting. Very exciting. Okay. So before we get going and start bombarding you with likely more elementary questions than you're used to, I am going to read through the learning objectives and disclosures. For those of you listening who have asked that I skip these parts, I can't. ASHA makes me read them, so I will get through them as quickly as possible. If you need to put your podcast player on a 1X or a 2X and fast forward them, I'm not going to tell anybody. So learning objective number 1, describe the difference between tracheostomies and laryngectomies. Learning objective number 2, explain the SLP's role in management of patients with tracheostomies and laryngectomies. And learning objective number 3, recognize external resources for acquiring deeper knowledge of complex airway management. Disclosures. Lindsay Griffin's financial disclosures. Lindsay is an assistant professor at Emerson College. Lindsay Griffin, non-financial disclosures. Lindsay is a member of ASHA SIG 13 and the Dysphagia Research Society. Kate Granbois, financial disclosures. That's me. I'm the owner and founder of Granbois Therapy and Consulting LLC and co-founder of SLP Nerdcast. My non-financial disclosures. I'm a member of ASHA SIG 12 and serve on the AAC advisory group for Massachusetts Advocates for Children. I'm also a member of the Berkshire Association for Behavior Analysis and Therapy, Mass ABA, the Association for Behavior Analysis International, and the corresponding Speech Pathology and Applied Behavior Analysis Special Interest Group.
Amy, that's me. My financial disclosures are that I am an employee of a public school system and co-founder of SLP Nerdcast. And my non-financial disclosures are that I am a member of ASHA Special Interest Group 12, and I serve on the AAC advisory group for Massachusetts Advocates for Children. We've done it, we've disclosed and given objectives.
Sometimes when you say disclosed, I think you say disclothed, and that makes me giggle. I just wanted to tell you that.
It's disclosed a word.
Go on.
Okay, we can research if that's a word.
We can be smart and funny at the same time. It's fine.
We definitely can. Totally. All right. Lindsay, why don't you start us off by telling us, I mean, like Kate said, we really don't know much at all here. Difference between tracheostomies and laryngectomies.
Okay, so they are actually quite different, vastly different, some would say, but are frequently confused from people who don't understand what they are. So a laryngectomy is usually, always, completed by a surgeon as a treatment for someone who has head and neck cancer, and it is permanent. It will it will never be better in the fact that the larynx is surgically removed, the voice box larynx.
And it does not grow back.
It does not grow back, no. So it is permanent. Whereas a tracheostomy can be temporary or permanent, and it is surgically placed as a way of usually helping with someone's breathing. Although there are instances in which they're prophylactically placed, so they're placed before somebody has difficulty if there is suspicion that someone will have difficulty.
And silly question, number one of many yet to come. Tracheostomy anatomically is below the level of the larynx, right? Like if you're picturing it in your head while you're driving along listening.
Yes, that is correct. It is below the level of the vocal folds. It's below the level of the larynx. So a small incision is made on the outside of the neck, and the trach tube is just sort of rested in that, and the trach tube sits below the vocal folds. Correct.
So do people get total laryngectomies for things other than cancer, or is it really exclusively as a treatment for cancer as the diagnosis?
I would say 99% of the time it is because of a head and neck cancer diagnosis, but no one ever, always, or nevers in medicine. So there's always, odd cases, but usually it's for head and neck cancer treatment.
Okay.
So as a clinician, you're probably more likely to encounter somebody who's had a tracheostomy than you are somebody who's had a laryngectomy, unless you're, kind of working in a place that's doing a lot of those types of surgeries. Is that fair to say?
Yes, that is fair to say. And in more recent years, there's been a big push for organ preservation. So the face of head and neck cancer has changed drastically over the past few years. So it used to be a disease that a lot of people got who were smokers and drinkers. And really, they just can't tease apart smoking from drinking. So they lump them together. It's probably mainly smoking that contributes to head and neck cancer. And then that cancer was commonly, if it was laryngeal cancer, was commonly treated with a total laryngectomy. But with less people smoking over the years, that type of head and neck cancer the incidences have decreased. And now we're seeing a larger rise of head and neck cancer spurring from HPV, which is human papillomavirus. It's a sexually transmitted disease, and it's the same, HPV is the same virus that they're looking for when women have pap smears in the cervix. HPV can lead to cervical cancer. And so when you have a pap smear, they know pretty much where the HPV likes to hang out. And so that's the area of the cervix in which they scrape. But in the head and neck cancer population, where HPV likes to live is a little bit more reclusive in the head and neck. And so it's not necessarily an area that they can just like scrape and find out if you have it. The other part is that HPV in some people clears up by itself and no problems develop. And then in other people, it can lead to cancer. So in the HPV related cancers that are occurring, the population tends to be younger, and they also don't have this history of smoking and drinking. And then the head and neck cancer can also occur in various places. So like the cheek, like the inside of the cheek, the tongue, the base of the tongue, the vallecula, the epiglottis. It still can happen on the vocal folds and around those areas, but usually the vocal fold areas are more aligned with inhalation of tobacco.
Well, that's scary.
Yes.
Yes, but with the HPV vaccine that came out a few years ago, hoping that HPV related head and neck cancers will also go down as more people receive the HPV vaccine. But now there's vaping. So TBD on the outcomes of that.
So would a patient receive a total laryngectomy if they had HPV related cancer in their cheek?
Yeah.
Is it a treatment that is like sort of like, well, we're going to take it all out just to be safe? Or is this a very specific to it being in the larynx?
Yes, it is.
I told you there were going to be very rudimentary questions.
This is fantastic. It is the total laryngectomies are and partial laryngectomies are in response to cancer of the larynx specifically.
Okay.
Okay. So these two different procedures are really different. We talked a fair amount about laryngectomies. It sounds like that's really specific to a cancer of the larynx, which that demographic is shifting.
Yes.
Because it's kind of a different reason that we're seeing people are coming in with these cancers. Tracheostomies, I feel like even when I was in grad school, I had some patients who had tracheostomies for a number of different reasons. I wonder if you can talk to us just a little bit about what some of the reasons might be that you might, as a speech pathologist, be working with somebody who has been given a tracheostomy.
Sure. So one of the biggest reasons that people get trachs or tracheostomies is because they have prolonged need for mechanical ventilation. So they've had some sort of medical illness, whether it's a stroke or they've had some sort of respiratory disease or something that takes them to the acute care hospital. And potentially, usually they are intubated first, which means the breathing tube is in their mouth, goes down the back of their mouth and then through their vocal folds and rests there. And so usually it's like taped across their mouth as well, so it doesn't fall out. And they're usually sedated to some extent. And that's so that they don't pull it out because it's an uncomfortable process. And so then that ET tube is what we call it, the one that's in the mouth, is then connected via tubes to a ventilator, which is a machine that's helping them to breathe at varying levels. So when someone is well enough, the medical team will try to take the ET tube out, or at least change the ventilator settings. And hopefully the person can now breathe on their own. Everything's fine. They breathe on their own. But in some instances, they aren't able to wean from the ventilator, and they've had the ET tube in their mouth so long that it's now we need to figure out a new plan. They're going to need ongoing support. And so then they have the surgical procedure where this incision is cut on the external part of their neck, and the tracheostomy tube is just laid into their trachea. That is one of the main reasons that somebody would get a trach. And then that trach can be attached still to the ventilator, and they can continue to receive that same level of support, but we also can wake them up now so they're not so sedated or not sedated at all, and get them sort of up and moving, which then all of those mobility components then increase their readiness for rehab and hopefully helps with their health.
There are a number of different pieces. I was wondering if you could refresh my memory a little bit about, there's not just one type of trach, right? There's a lot of different, like,
I remember the word cannula. Is that a word that is used?
Ooh,
right?
That is a word that's used.
You get points.
Good memory. So there are some trachs that have double cannulas. Kate, using your word. Yeah. And so they have the part that goes in the person, but then inside of that is another tube. And that is really just for cleaning purposes. So if a person has a lot of secretions, they tend to have a trach with a double cannula, so that you can take out that middle one, clean it, or replace it, and then but you don't have to actually replace the whole trach. Trachs also can have a cuff. And so that if you are looking at the person outside of their body attached to the trach, there will be kind of like this little balloon filled thing that's hanging off of their trach. And that corresponds to sort of a little balloon thing inside their body that's wrapped around the outside of a trach. And so when there is air in the balloon outside of their body, then the balloon that's inside their body is also full of air. And what that does is that it closes off their upper and lower airways from one another. And so they're really just breathing in and out of the trach that is in their body. Whereas if the cuff is deflated so that there's no air in it, or if it's a cuffless trach, then air can still move around the trach and up through the vocal folds and then up through the upper airway. Whether or not someone can be successful with voicing, with their cuff deflated or with a cuffless trach depends on a lot of their personal factors, like the strength of their respiratory system, for example. So maybe they have a really strong respiratory system, and so they can get enough air up through the vocal folds despite having this also hole in their neck that is a tracheostomy. And so their vocal folds can still vibrate and still reverb up through their resonance tract and then be articulated and still make speech. But some folks aren't able to do that. Another variation of the trach is the size of it. So 8 is a pretty large one, and it is the diameter of the trach is what the number refers to. And then a 4 is a pretty small one. So usually like a 6, 7, 8 are the more common ones in adults. And so if somebody has an 8, for example, that hole, that external hole, which is really the trach tube in their neck, is going to allow more air to go out of it, and it's going to take up more room in the trachea versus a 6, for example, which is going to have a smaller diameter. They might be able to push more air up past it through the vocal folds and use that air for speech. Does that make sense?
That makes so much sense. That was so informative. What about speaking valves? Are those a thing? Is that a thing?
Those are a thing. Before I talk about speaking valves, I just wanted to sort of go back to your other question about why people might get trachs. In addition to prolonged need for mechanical ventilation, another reason that somebody might get a trach is prophylactically, so before they actually need it. And we see that sometimes in the head and neck cancer population or the ALS population. And so with head and neck cancer, if their cancer is close enough to the airway that the medical team suspects that when the person begins to receive chemoradiation and things start to swell, that it might occlude their airway, then they would get a trach placed prophylactically just while they're undergoing treatment. And then once their treatment is over, then it would be removed. For folks with ALS, some choose to go on a ventilator, sometimes at home, as the disease progresses. And so even before they need the trach or vent for actual breathing, sometimes they have the trach placed so that when it comes time to need mechanical ventilation, they will just have the trach as well as actually the G-tube usually placed surgically as well, because both of these, the trach and the G-tube, require some anesthesia to be placed. And usually by the time that they get to the point where they need the trach for breathing, then it becomes a little unsafe for them to have the anesthesia. So they can sometimes have it placed early as well. And then the final reason that I'm going to mention is usually for secretion management. And you tend to see that, you can see it across the lifespan, but in kids, sometimes you'll see trachs placed for if they just have a lot of secretions and they're aspirating that, and they need a lot of, we call it pulmonary toileting. Basically, they need like a lot of suctioning and help to get their secretions up. Then a trach can be placed to help with those things. Because the other thing about trachs is that it allows for direct suctioning of secretions with a suction catheter that you being SLPs as well, can put in the trach on the outside of the person's body and suction the stuff that's hanging out beneath it.
That was always
a lot of vocabulary that I'm just not familiar with, particularly pulmonary toileting. I've never heard that term. Is that really what it's called?
Yeah, feel free to use that.
It's pretty catchy.
So you've given, this sounds like a very complicated process. It sounds very intimidating. And I have a question that's related to our next learning objective in terms of safety and training. So when an SLP is involved in the team, I'm thinking about myself as a new grad. There is no way that I would have been qualified to do any of those things. And I know we go into our workplaces and we have supervisors and we have CF supervision. But I'm under the impression that this is a medically fragile situation that requires a lot more training for safety purposes. Is that an accurate assumption?
Yes, this is a population that tends to be more fragile, and you do need some extra training. When I was interviewing for CFs, I didn't have any experience in complex airway, and I really wanted some. So when I got my CF, I was hounding my CF supervisor repeatedly for experience in complex airway, which she eventually granted, which, I mean, it makes sense that it wasn't like day one, but I wanted it to be. I was so excited. So I always tell students that anytime that they can even just be in the room with somebody who has a complex airway and asking questions about it, that it is good to have in your back pocket.
And I mean, there are also, I'm sure, a lot of other professionals that you can learn from, not just the speech pathologist, but maybe respiratory therapists,
Definitely.
Physicians, surgeons. It's such a specialized area of the field.
It is. It is. ENTs, surgeons, pulmonologists, and definitely respiratory therapists. I would say even respiratory therapists are the most accessible of the list that we just went through. And when I worked at an LTAC, a long-term acute care hospital, as my CF. And so our respiratory therapists were just like wandering around caring for patients. And I'd be like, hi, can we talk about what PEEP is? Because I just couldn't understand some of these terms that I was reading about. So, and they were obviously so helpful.
What's PEEP?
PEEP is, I don't know why it took me so long to understand what the heck this is, but if you think about your lungs and there's these little air-filled sacs that just keep getting smaller and smaller and smaller. The smallest of them are called the alveoli, and everyone's alveoli have tiny bits of air in them to keep them inflated. They cannot be completely deflated or we will suffocate. And so that air is called, that tiny little bit of air in the alveoli is called PEEP. And the reason that it was something that kept coming up in notes was that when somebody is on a ventilator, one of the settings is the amount of PEEP that the vent is providing to the patient. And sometimes that can be the higher levels of PEEP that they're receiving means they need more vent support than somebody who has a lower amount of PEEP. And so I understood that concept, but I wanted to know, but what the heck is PEEP? And one day, Claire, the respiratory therapist, finally got through to me. And I was like, oh.
Claire, the respiratory therapist, has now contributed to educating however many people are listening to this. So thank you, Claire. It's a trickle-down effect of knowledge right there. There you go. This is why we need to learn from our peers more often.
That's right. There's also really great external resources too that anyone who's wanting experience with complex airway should definitely think about. Passy-Muir valve, which are the speaking valves that Amy, you mentioned, and I would love to talk more about. But Passy-Muir is one of the bigger names of the speaking valve companies. And they have a ton of free resources on their website for clinicians about what the heck is a speaking valve and how do I assess for it and what things do I need to know. And they also have really great reps who will come out and do in-services to the whole rehab community at your hospital or whatever the case may be, if you request them. And
it's funny because one of the things we were talking about before we started talking with the recording feature on was just these funny analogs between the area of AAC where Kate and I work and, this area of dysphagia. And I think that that's one piece that's another kind of commonality is, having these relationships with the vendors of the equipment that you may be using with your patients and just knowing that they are a resource where you can learn so much and don't hesitate to kind of seek that information out and learn more from the people who are actually making the products that you're using or might be using.
Absolutely. And I'm pretty sure Passy-Muir has, I'm pretty sure they have free ASHA CE courses for free ASHA CEUs on their website. Just as
they
another,
absolutely do.
Which is also resource.
Great. And then another brand is called Shiley, and Shiley has some resources too, but not as well known as Passy-Muir, or PMV is also Passy-Muir valve, the lingo. I will say that a lot of the research that Passimir talks about on their website, they paid for that research.
Okay.
So, be aware of potential bias, but the product is a good product and very well used, and they do offer free CEUs.
There you go.
It can be a wealth of information.
Well, that sort of brings us to a more direct question about our second learning objective about the SLP's role. So, as quote unquote experts of the larynx area, assuming that an SLP who is interested in learning more about this has accessed the resources that I know you haven't totally finished telling us about, but you will. So interested in this area, consuming a lot of resources, consuming a lot of CEUs. Let's even pretend that they have a mentor or a supervisor who's going to take them under their wing, which I know is not standard in a lot of work settings, but let's play pretend. Since we have two very different presentations between a tracheostomy and a laryngectomy, how does the SLP's role differ between those two presentations? I guess would be my first question.
So for tracheostomies or trachs, it tends to be more short term. Not for everyone, but a majority of people. And so one of our biggest roles is assessing for speaking valve tolerance. And that can be done in an acute care. It can be done at any levels of care, even outpatient. And speaking valves are typically thought about going on trachs, but there also are speaking valves that are called that are speaking valves, but they're inline valves. And so somebody who is vented with a trach can also use a speaking valve to be able to communicate, although that is, in my experience, done less often, because if somebody is vented, they maybe are on the way to not being on the vent anymore. And so sometimes healthcare facilities will just wait until they're off the vent. But in some instances, it has been that, in my experience, it's been really effective ways for people to communicate their medical wishes, have conversations with loved ones, with healthcare providers, or just be able to communicate that their foot itches and they wish somebody would scratch it. So inline valves certainly are something to consider, but I think that the more traditional thing that we think about is putting a speaking valve on somebody who's trached but not vented. And a speaking valve is a one-way valve, so it allows air to go in to the person, but then when they exhale or when the air is coming up from the lungs, the valve closes off, and then the air is forced up through their vocal folds, through their resonance tract, and through their articulators, so that they have speech similarly to how we do.
I mean, obviously, speech itself is a super big benefit of a speaking valve. Are there other benefits to using a speaking valve as well, in terms of maybe oral care or
swallowing, maybe?
Yeah. Swallowing.
Yes. So there is research to suggest, and Passimir is the maker of some of this research, that when somebody's wearing a speaking valve and they have more of a restored function of pressures and sensation and connection of the upper and lower airways, that their swallowing can be safer as well as a result. And so there is push for somebody to eat with a speaking valve, although depending upon the person, plenty of people can eat without speaking valves as well. But if you think about the primary reason that somebody has a speaking valve, which is the fact that they had this prolonged need for mechanical ventilation, if you think about it from like a rehab, getting stronger sort of spectrum, okay, now they don't need mechanical ventilation, they have just a trach. Are they strong enough to be eating orally, or do we really need to be working on the breathing aspect first? So I always tell my students in dysphagia that breathing trumps swallowing. Somebody needs to be able to breathe before you can swallow. And so maybe somebody has an open trach, which means no speaking valve, majority of the time, but they can handle some speaking valve trials. And if their respiratory system was stronger, they could wear the speaking valve all the time. So then you would have to balance, is the respiratory system strong enough to eat if the respiratory system is not strong enough to tolerate a speaking valve all the time? So sometimes that is the decision for why they're not eating yet, because they still need to get stronger from the respiratory perspective. So then, assuming they're able to tolerate the speaking valve during all waking hours, then following that, they usually do capping trials, and then which is basically just like closing off the trach tube and basically restores the airway to typical functioning. And once they're able to tolerate capping trials, then the trach is just literally removed. It's very simple. And the incision usually closes up very quickly within like 24 hours, but it will sometimes have gauze over it just to keep it clean. So usually when someone is wearing a speaking valve frequently is when we start to think about swallowing. Not in all instances, but certainly in a lot of instances. So speaking valve can help with that. One of the biggest things I would like to say about speaking valves is that if somebody has a cuffed trach, so that's that balloon that's hanging out the side of them, and that balloon has air in it, then the balloon that's inside that's also wrapped around their trach also has air in it. If you put a speaking valve on somebody while both of those balloons have air in it, they will suffocate. So it is incredibly important that you only place a speaking valve on somebody when the cuff is deflated. And that is, again, because the speaking valve is a one-way valve. So air comes in the speaking valve, but then basically the person can't exhale because the cuff is inflated. So there's no way for the air to go up through the vocal folds, but also the speaking valve is present. So there's no way for the air to come out of the trach. And so they can suffocate. So it is incredibly important to only place a speaking valve on someone who you have tried to pull out all of the air from a cuffed trach.
So just to say that one more time.
Yes, please.
I was going to say, I'm sitting here with this very serious, that sounds horrible.
Never putting a speaking valve on an inflated cuff.
Yes. And if you don't know what those words mean, then just don't place the speaking valve.
And I feel like if you don't know what those words mean, you should maybe seek some additional supports or continuing education or supervision or something before you're in a position to be making that decision in a vacuum. If someone's life is on the line, that's a really big deal and a tremendous responsibility.
Agreed.
Okay, so we've talked about I have so many additional questions too. But before I get to about the medical team and collaboration with other professionals, presumably you are not doing any of these things by yourself as the SLP. You're doing these things in conjunction with respiratory and nursing, I would imagine, and all these other kinds of things. Can we shift a little bit for a second and talk about the laryngectomy portion? So yes. What is the SLP's role for a patient who has had a laryngectomy?
Okay, so as we talked about, the larynx is removed during a laryngectomy, which means the person is no longer able to speak like we can.
I'm still giggling when Amy said, and it can't grow back because that's like the funniest. Of course it can't. I just thought it was so funny. Can grow back. There are funny parts of the body that,
but it's just the liver, right?
I think so.
Is there another part of our body that can grow back? Okay, we can table that for another time.
So
the total larynx, the SLP and the laryngectomy.
I was like, what are we talking about? Yes. So it is removed, and so they can't speak. And so if you can see someone before they have the total laryngectomy, then certainly part of your role would be trying to figure out if they would be open to doing some voice banking, because then we could potentially build a voice for them after their laryngectomy, which still sounds like them, which can be huge. There are some companies that specialize in using your own voice to build a huge collection of everything you could want to say. But then there are also just some instances of like recording some well-known phrases on your phone that then you can play to your loved one, like telling your partner that you love them, or reading a book to your kids, or whatever. Maybe you always say that one silly phrase, and so people are going to miss hearing that, and so you say that. So trying to record some things that are meaningful for the person if they're open to it. Some folks, when they're diagnosed and then find out they need a total laryngectomy, are just in such shock, and they're like, yeah, I'll get to it. And then maybe they never do. So obviously approaching it with caution, but if you can see someone before the surgery, that's a great strategy, as well as talking to them about what methods of communication they're going to use immediately after surgery. And also, of course, doing education about like what it's going to be like after surgery when they can't communicate in the same way. So some people write, some people get AAC devices, some people do this voice banking. There are, like low-tech AAC boards that are in the hospital that people can point to, like I need to go to the bathroom, for example, things like that. But trying to restore communication the best that you can beforehand and giving people an idea of what it's going to be like after. Because as Amy said, larynx doesn't grow back. And so this is permanent. And then let's say they have the total laryngectomy, they're able to communicate in the short term. And now that things are more stable, the next thing that we think about is restoring speech. And there's 3 main methods that we can do that with, depending upon the person. And so, yeah.
I think I remember 2 of them.
Ooh, tell me.
And I'm going to let myself be vulnerable here and see if I can. So one of them, there's a device that causes vibration that can be shaped by the pharynx, right?
Yes. That's called the electrolarynx.
And then
it's a brand.
And I want you to tell us about all of these in more detail before I list them. So but the other one is a method where you swallow air and use vibration with the top sphincter of your esophagus.
Yes. Wow, look at you go.
Right?
Yeah, that's called
I learned something in graduate school. I was paying attention most of the time. I don't remember the other ones. But go ahead.
Amy, do you want to contribute?
Amy, do you remember the third one? Dream Team, come on.
No, I have nothing to contribute to this other than saying I asked Google and the liver is the only organ that grows back. So disappointment.
Thank you for asking Google for all of our listeners who were on the edge of their seats about body parts that grow back. Okay, so those are 2. What's another one?
The third is a tracheoesophageal puncture, which is frequently just abbreviated to TEP.
Tracheoesophageal puncture.
Yes.
What is that?
Okay, so the TEP, the surgeon creates a hole between the back of the trachea and the esophagus. And then the patient will have a prosthesis placed, which is a one-way silicone valve that allows the air to flow from the trachea to the esophagus. And then to speak, they have to close off the stoma or the hole that's on their neck now, which is a direct access to their trachea. They have to close that off, usually with a finger, to redirect the air through the TEP prosthesis, unless they have a tracheostoma valve. Then the air just naturally goes through and they don't have to place their finger. And this tends to be a source of confusion for anyone who works with patients, but not necessarily in complex airway. When I worked in acute care, we would get many consults for patients who were coming into acute care for something unrelated to their airway. Maybe they fell and broke their hip. Maybe they had a heart attack. And many years ago, they had a total laryngectomy and they had something different about their neck. And so the medical team would consult speech and say, this person has a trach and we don't know how they communicate. But then when you would go and speak to the patient, it's just an old laryngectomy with a TEP, and they have no problems with it and they didn't need to see us at all. So because the stoma is present on the outside of the neck, and also sometimes there are some things in that stoma that help the person to talk, it can be confusing for people who don't work in complex airway. So sort of thinking like 5 steps back, when the larynx is removed from a total laryngectomy, the trachea is basically rerouted to end at the neck. So there's a hole, that's a permanent hole in the person's neck, and now they're called neck breathers by some people. And that can be important to know, because when you are giving somebody CPR who has a total laryngectomy, you actually have to give the breaths on the stoma, the hole in the neck. versus on the mouth and nose, because now the upper and the lower airway are no longer connected, which is also why some people in hospitals are confused about the presentation in front of them. So
wow. Okay. That was a lot. My anatomy is really rusty. So I have the diagram in my head, but keep going.
Okay. So part of the SLP role is to help with placing the TEP and then also doing TEP changes, because this like little silicone valve is in the person's stoma forever. And so, sometimes it gets dirty and needs change so that it doesn't cause any infections, or sometimes the stoma will get bigger. You'll need a different size, things like that. And so some people can do those on their own. And then other people, depending upon the TEP, would need help from an SLP to do that.
Interesting. So tell us about the other ones that I mentioned, the electrolarynx and the sphincter one.
Yeah. Okay. So the artificial larynx is the main brand is electrolarynx. So they're sort of used interchangeably, kind of like saying PMV versus speaking valve. Again, they're just a brand name versus not. And so the artificial larynx generates sound. It makes this buzz sound. And when the person holds it up to their neck, or there are some that you can place it in your oral cavity in your mouth, then they're able to shape that sound, that buzz that's created from the artificial larynx, and shape that using the speech articulators and make speech. And so I think like within the past few years, I've seen plenty of commercials about like don't smoke or you might have a voice box like this. And so if you can remember those commercials, that's what it looks like. Esophageal speech, like you mentioned, the person basically like swallows air and then kind of like burps it out. And as they're doing that, it makes the PES, which is the pharyngoesophageal segment, it's the top part of the esophagus, it makes it vibrate. And then they can shape that vibration, again, using their articulators to make speech. But this doesn't work for everyone based on the amount of tissues that were taken during the total laryngectomy. Sometimes there's not enough PES or pharyngoesophageal segment to vibrate to produce sound.
I would also imagine that would take some training. I mean, in order to learn how to do that, so that, I mean, everybody's heard their younger brother burp the alphabet, right? But you want, as a speech pathologist, as a professional trying to empower someone to be able to communicate with their best self, I would imagine that would take some training to make it sound in such a way that they was aligned with the patient's wish to communicate, I guess.
Yes, for sure. Both using the esophageal speech method as well as using the artificial larynx both take practice, and SLPs can help with both of those things. The artificial larynx especially usually has to be placed in a certain location, and that's variable among the patient. So sometimes it's just about moving it around and finding that sweet spot that gives them the best voicing.
Interesting. Is there any drawback to the esophageal speech in terms of constantly putting air in your esophagus? Does it have are there any other side effects like reflux or consistent need to burp because all the air didn't come out or something? I don't know. Are there any other like drawbacks to that method?
Not that I'm aware of from like a anatomy physiology perspective. Some people can be quite good at it, whereas others just maybe can never get it. So it's more individual variability, and also about like which parts are still remaining. Do you have enough tissues to vibrate?
Mm-hmm. Okay, so let's talk about the team. You're part of a team in this environment, I would imagine 100% of the time.
Yes, this is true.
Well, who are you working most closely with most of the time? Which individuals?
For laryngectomy, if it's a new laryngectomy, you're going to be working with usually like the oncologist, the ENT, who also tends to be the surgeon, but if they're not, then a surgeon, respiratory, nursing if they're inpatient, obviously the patient and family. And if you don't know a ton about laryngectomies, another SLP who does. And then another resource that's pretty good for laryngectomies is similar to Passimir makes speaking valves. Bloom Singer makes laryngectomy supplies, and they also have a lot of really great continuing ed resources on their website. And then they'll also do in-services, and they have really great like patient support systems as well. So if a patient contacts them, they'll give them samples of things to try to see if they like it, and provide a lot of education. I don't think that their educational materials on their website offers ASHA CEUs, but it's still a great learning resource for sure.
And are there overlapping scopes with other professionals that can be difficult to navigate in terms of what our role is on the team as SLPs versus, it just sounds like there are so many moving parts and it's so complicated. I have to imagine that there are some shared responsibilities that could be determined by workplace norms or licensure standards.
Yeah, I'm sure there are like about caring for the laryngectomy, and also like who gets to educate the patient on the laryngectomy. I think pretty much probably everyone educates the patient on some level about what those specific instances are. But I think for the most part, it's understood that we're there to help with communication and speech, and that really is like pushed and understood as part of our role and under our umbrella. And I think mainly the other members will say, well, talk to speech about that because I mean, who doesn't want to be able to communicate, as you fine AAC ladies know?
Well, and you mentioned earlier voice banking and how, some patients may choose to do some voice banking if that's something that's an option available to them. And I did just want to put out there, John Costello at Boston Children's Hospital has done so much with voice banking that not that I know much about using it in the context of a laryngectomy, but that might be another really nice place to look if you are an SLP who's interested in learning more about that.
Yeah. Yeah, he also does it for ALS too. So not just for the head and neck cancer population. I was recently, like within the past year or two, was at Boston Children's in Waltham, where John Costello works, because my son has had tubes in his ears, and we were just going for like a regular checkup. And we were waiting in the waiting room, and I heard a voice behind me come out and introduce himself to a patient and said, "Hi, I'm John Costello," and whatever the instruction was. And I whipped my head around as if I had just seen a celebrity. And I was like, said to my 3-year-old at the time, "That's John Costello." And he was like, "Okay." Like, no, but like, he's kind of a big deal here. It was a very celebrity sighting for me. He has no idea who I am, but I did see him in person once. I didn't get his autograph, but I should have.
So he was my professor, and he's the nicest man. Hi, John. If you're listening, I'm sure you're not, but I've shared cases with him. He's just the most collaborative, wonderful clinician. And if anybody is listening, is interested in reading any of his work, I know he's published a couple of things through Children's Hospital with Howard Shane. He's just contributed so much to the field. So thank you, John, for your work, and you're the best. And maybe we can convince you to come on as a guest sometime, but that's another topic for another time. Okay. So
100% do that.
I'm thinking about SLPs who are listening, who, we've gone through, not only the difference between these two things, but there are different levels of complexity, the different levels of knowledge that you need to have, the roles on the team. Let's talk a little bit more about our last learning objective in terms of other resources and things that SLPs can do to expand their knowledge base in this area. Because as you said, having been the SLP and their CF really is like chomping at the bit to get this experience, I'm operating under the assumption that this is something that not a ton of SLPs have a lot of competency in. Is that a fair assumption or not?
Yeah, I think that it is a fair assumption. And I also think that it's important to like differentiate that just because someone has experience with trachs doesn't mean that they would have equal understanding of or experience with laryngectomies, and vice versa. So even though they're both dealing with the airway, they're both dealing with the airway in much different ways. And so just because you have access to materials about one doesn't necessarily mean you would have the same access or knowledge about the other. I have a ton more experience with trachs than I do with laryngectomies, even though I worked on a head and neck cancer multidisciplinary team when I worked in acute care. So, you never know. In terms of like ways that you would seek information, always continuing ed classes, always your colleagues from varying disciplines, as well as the SLPs that you work with. And then these companies that make these devices or pieces also have a lot of these really great continuing ed information on their websites. And articles are always a great place to gain information.
I would imagine too that it's the type of placement. Just having had a placement like this when I was in grad school, I worked with it. Part of my placement was acute care, subacute care, trach and vent. And it definitely seemed like it was sort of hard to get into that area of the field if you wanted to. So I think it seems like the type of job that there would be kind of a long onboarding process relative to SLPs who maybe go work in a public school. You're kind of, here's your caseload, go ahead, run with it. I would imagine it's a different experience if you're working with people who are having tracheostomies or laryngectomies.
Yeah, for sure. For example, like when I was doing inline speaking valves in acute care, I never did that without having a respiratory therapist with me. It wasn't something that I was comfortable doing on my own. Part of that is because the vent beeps continuously because it thinks the person is not getting the oxygen or the support that they need. And so part of that is that the respiratory therapist will monitor the vent settings, which is something I've never done. Mainly, that is always something that the RTs have done when I'm doing anything that requires modification of vent settings. That is their job. I don't understand the vent nearly to the extent that they do.
Well, and we talk a lot on this show about scope of practice and scope of competence, right? Because technically, we all pass the praxis. We're all speech language pathologists here, but very clearly this is not in my scope of competence, nor is it in Kate's scope of competence. And we talk a lot about like that self-awareness as a clinician and how important it is to know what you don't know and know when you need help and know when you need to collaborate with other people. Mm-hmm. And I would imagine that is to some extent even more important in a medically based setting.
Yes, absolutely. Do not have a false sense of, I got this. Certainly seek out help. I usually tell 3 cautionary tales about my false self-confidence when I was practicing. Would you like to hear them?
Yes, please.
I would like to, and then I'll feel afraid.
Yes, you should. Okay, so the first is that when I was working in acute care at one point, I had a patient who I thought had his cuff deflated before, and turns out he had not. And I was fitting him for a speaking valve for the first time, and I deflated. He was sitting in the chair. His sats were 100s perfect. He was satting in the 90s. You want him to be above 90, and so that just means that his oxygenation was good. And so I deflated his cuff and put the speaking valve on him as one does. And he was fine for a few seconds, maybe a few minutes. And then all of a sudden his sats started dropping and dropping and dropping. And they dropped to like the 70s. And yeah, it was very bad. And he was in the ICU. So he had, a lot of nursing support. And the nurse came running in because she could see the monitors going crazy. And basically we got him back under control and he was okay. But really I did that because I didn't suction him before I deflated his cuff, and everything that was sitting on top of the cuff just fell into his airway and caused him to desat. So my cautionary tale number 1 is to always suction the patient's trach before deflating the cuff, whether you think they've had it done or not.
Lesson learned. I'm very scared. Move on.
Yes. Okay. The second one was even worse, actually.
Oh,
I don't get like my license revoked for telling these stories. So the second one was I had this patient who was in the LTAC. He had just recently had a trach placed prophylactically because he was going to be having chemoradiation for head and neck cancer. And he had a very large base of tongue mass. And they were afraid it was going to occlude his airway as he swelled. And so he had the trach. It was an uncuffed trach. And he was very sad in the room when I first met him. And I was seeing him for a speaking valve evaluation as well. And because he had just had the trach placed, usually around the trach on that outside a person's neck is a piece of gauze. And that's usually like just for comfort. And then also attached to the trach is kind of like a foamy thing that is Velcroed on each side. And it holds the trach in place because otherwise the trach could just fall out. So I thought, I'm going to do a really nice thing here and change the gauze that is under his trach, because it was like really bloody and full of secretions. And like, if you're already sad, who wants to then have that, right? So I removed both Velcro pieces from the part that's wrapped around his neck, keeping the trach in place. And I took the gauze out, but before I could put the gauze back in, he coughed and his trach flew out of his body and onto the floor of the hospital.
Oh my God.
Oh, it's a bad place for your trach to be.
Yes, that is true. Yeah. I mean, like, thank God he didn't need it for breathing at this point in his life. It was just prophylactically placed. So they had to call code blue, and respiratory came running in and they gave him a new trach, and he was okay. But that is still a horrifying experience that I did do that. And respiratory, then we talked about it. There was an incident report. I'm not above saying that. And which is fine. Should have been. They said that in the future, should I want to remove anyone's gauze, to just undo the Velcro on one side of the trach tie, not both, and keep your hand on the outside part of the trach, which is called the flange, so that should they cough, it would still remain in their body.
Okay, lesson number 2. Only undo one side and keep your hand on the flange.
Yep, that's right. The third cautionary tale was, as you recall, I said I was desperate for trach vent experience during my CF. So on the very first patient that my CF supervisor took me to see, who had a trach, I was just like, I was in it. I was standing at the edge of his bed. I was just watching everything that was happening. And the first thing that she did, C point number 1, was she suctioned him. And so you put the suction catheter in the person's trach, and sometimes that will make them cough. So I was standing at the edge of the bed, ready to go. And when she suctioned him, he coughed so strongly that his secretions shot across his bed onto my face and onto my scrubs.
It's my favorite story.
Oh my goodness gracious.
Lesson number 3 is not to stand in front of an open trach. My CF supervisor was standing to the side of the patient when she suctioned him, as I should have been doing as well.
Wow.
And then I always carried extra scrubs in my locker. So that's maybe lesson number 4.
Wow.
These stories are so good.
First of all, thank you for sharing, because all of us who are seasoned clinicians or who go on to be researchers make mistakes, and that's how we learn. Vulnerability is a key component of moving our lives forward. So thank you for sharing.
Yes.
And it's also making me think that anybody who is listening who wants to learn more about this, the importance of having peers and colleagues and mentorship. And I encourage everyone to find someone and reach out to someone. I mean, so part of our podcasting adventure is contacting people. And I would say 9.5 out of 10 people, almost everyone in our field, at least that we've contacted, is excited to share their knowledge, excited to teach, excited to participate in exchanging, giving knowledge onto people who are looking to learn. So if you're listening and you really want to learn more about this, I would encourage you to start contacting people, find someone at a local hospital. People are often really open to mentorship. It's not a norm in our field to ask, and it's not a norm in our field to have that as a component of your job. So not that making mistakes is still impossible with a mentor, but it's really nice to have someone you trust to say, hey, I did this wrong. Can you tell me how to do it better? And be vulnerable with that person in terms of, learning more.
Because it's impossible to do everything perfectly. Here's just your little self-help reminder of the podcast.
Amy has to remind me of that all the time for everybody.
It's impossible to be
who's
perfect.
Listening. So it's true.
People aren't perfect. We all make mistakes. That's part of what makes us people.
I just told you 3 of my largest mistakes of my life. And I also would just like to clarify that those 3 things happened over the span of several years. I wasn't like Nurse Ratched going in there murdering every trach patient. It was I would do a lot of really, really good things and then periodically make these terrible mistakes.
And we all do.
But even if it's not, something that you look back on and cringe overtly about, I think that really is something that Kate and I talk about a lot on this show. I think is the idea that if you're not constantly sort of reflecting on your practice all the time, even those of us who have been doing this for quite a while at this point, there are still things that I'm doing now today that I will look back on in 5 to 10 years and think, oh, I did that, huh? Wow. So, I think that's part of just being a reflective clinician also. And then you learn the big things, like don't stand in front of an open trach.
Yeah, that's true.
In our last couple of minutes, are there any additional resources or parting, closing thoughts that you want to share with our listeners?
I think something that I would say is if this is something that you're interested in, definitely seek out the resources. Do the book learning component of it, and then seek out a person who will be with you every step of the way so that you're not standing in front of the trach and you're not letting trachs fall out and you're learning how to suction people and putting it all together in a way that is the safest for the patient. And this is an area that the patients are fragile and you do want to treat them as such, but also you aren't working alone on this. And so barring any just terrible decision, like the 3 I shared with you, the patients are going to be okay. So they're fragile. You should be aware of that, but you also shouldn't be afraid of it either, because you are functioning on this team in a way that everyone's trying to do the best for the patient, and just leaning on those resources, I think, is important.
You're the best. Thank you so much for coming and hanging out with us again. You're so knowledgeable and just fun. This was really, really great.
Thanks for having me again.
Lovely.
Well, maybe we can convince you to come back for a 3rd installment, but we'll see. We just really appreciate all your wisdom and storytelling, and you've just got so much to share. So thank you again for being here.
Thank you. I appreciate it.
And to everybody who is listening, if you are driving, running, biking, folding laundry, whatever you're doing, there will be a list of resources in the show notes. That is so in case you couldn't take notes and what was that book or what was that website? Everything is listed in the show notes, in your phone, in your podcast player. It's also listed on our website if you want to reference it again in the future. And I think that's it. Thanks again, Lindsay, so much for joining us.
Thank you.
Thank you so much for joining us in today's episode. As always, you can use this episode for ASHA CEUs. You can also potentially use this episode for other credits depending on the regulations of your governing body. To determine if this episode will count towards professional development in your area of study, please check in with your governing bodies, or you can go to our website, www.slpnerdcast.com. All of the references and information listed throughout the course of the episode will be listed in the show notes. And as always, if you have any questions, please email us at info@slpnerdcast.com. Thank you so much for joining us, and we hope to welcome you back here again soon.